I'm Dr. Larry Dean, the director of the UW-Madison Regional Heart Center, and I'd like to welcome all of you to UW-Madison Regional Heart Center Grand Rounds. Our topic today is valve surgery in young adult, valve replacement options. Dr. Daniel Velez will be presenting our case. Dr. Velez is a chief resident in the Division of Cardiothoracic Surgery in the Department of Surgery at the School of Medicine at the University of Washington. Dr. Velez.
Thank you, Dr. Dean. Today I have a case of a 23-year-old woman who presented to the Congenital Heart Center Disease Clinic with increasing shortness of breath, decreased stamina for the last year. It's important to note that her surgical history is significant for the first complete repair of a truncus arteriosus at the Boston Children's Hospital dating back to 1981. Repair of a truncus arteriosus entails the closure of a ventricular septal defect and the replacement of the aortic or truncal valve, as well as a right pulmonary artery to right ventricular conduit. She had to undergo a redo truncal valve replacement or aortic valve replacement at that time at the age of 8. At that time she had a mechanical valve placed, 19mm valve. And she does have some risk factors. Particularly, she stopped taking Coumadin at the time she came to see us in clinic. This shows a view of a patient with truncus arteriosus in the operating room. You can see that the defect basically entails that there's only the single vessel coming out of the heart, and this vessel gives rise to the coronary arteries, as well as the ascending aorta and the pulmonary arteries. Almost always, all patients will have a ventricular septal defect as well as a single semilunar valve. Repair of a truncus arteriosus is done by making a right ventriculotomy to later on expose the ventricular septal defect and patch it with either a PTFE graft or a Dacron graft, as well as detaching the pulmonary artery from the truncal vessel and closing it with a patch as well. Later on, after closure of the VSD, a pulmonary homograft is used as a RV to PA conduit to reestablish continuity. This is what the surgical specimen would look like after repair, where you have a proximal hood, the homograft, and the patch on the aorta. When she presented to clinic, we confirmed that she's had a murmur for many years, but pretty much her exam was unremarkable. She was in sinus rhythm, she was tall, slim, with no other problems. A preoperative echo shows here a tight left ventricular outflow tract with turbulent flow through the 19mm valve that was obviously too small for her at that time. The echocardiogram also showed pulmonary valve stenosis and regurgitation. The gradient across this valve was 60 millimeters of mercury. The gradient across the pulmonary valve was 110. We took her to the operating room in July of 2004, and she underwent an aortic root enlargement procedure. We replaced her aortic valve with a 23 millimeter stented bioprosthesis. We also enlarged her right ventricular outflow tract and replaced the pulmonary valve with a 21 millimeter stented bioprosthesis as well. We approached this in the operating room by making an incision from the homograft down well into her RVOT, and also performed a aortotomy to expose her aortic valve. This is a depiction of a similar procedure that we carried to enlarge her root. We made the aortotomy at the base of the aorta. We carried the incision down through the annulus, not quite in this position, but more through the non-coronary cusp, and placed a patch to achieve a larger diameter of her annulus. And we went from a size 19 to a 23 millimeter valve. This is what it would look like at the end of the procedure. Here you can see the aortotomy, the right coronary ostia. This is the annulus where the aortic valve was sitting, and the patch being sewn into place. And at the top over here, we have the incision on her homograft. This is almost at the completion of the closure of the aortotomy. Now the patch is in place, her aortic root is enlarged, the 23 millimeter valve is in, and we're about to direct our attention to the pulmonary side, where a 21 millimeter bioprosthesis was then placed, and the whole RVOT was enlarged with 2 patches. This is what the specimen looked at the end of the procedure: a much larger right ventricular outflow tract and an enlarged aorta or aortic root with the valve within it. Postoperatively, she did very well. Her hemodynamics were within normal limits. She was sent to the floor on post-op day 1 and discharged home on post-op day 4. As you can see on the post-operative echocardiogram, now her left ventricular outflow tract is much larger, and she has a valve well in place, functioning very well. Our procedure was not in vain. You can see that the gradient across the aortic valve went from 60 millimeters of mercury down to 9 millimeters of mercury, and in the pulmonary position, the valve went down from 110 millimeters of mercury to 10. I will now leave the podium to Dr. Ed Verrier, Chief of our division.
Well, thank you, Dan. We elected to present this patient because we think it represents a number of interesting aspects of dealing with young people who have aortic or pulmonary valve disease, or what we call outflow tract disease. And it represents an increasing group of patients because there are a number of children who had repairs of congenital anomalies in early childhood that then proceed. And with growth, we then have a change in the relationship between the valve, which was put in this child at the age of 8 months old, up until the point where she's 23 years old. And her heart has grown around a relatively small valve. And so she has a mismatch between the size of the valve. Not only did she have a mismatch on the left side of her heart, she had a mismatch on the right side of her heart, because what was put in at age 8, which was an RV to pulmonary conduit, also tends to deteriorate over time. It's not built because it's a bioprosthetic to last forever. So I think she presents an interesting set of issues for us. What kind of valve to put in now that she's 23? She has a young suitor. She's interested in marriage. She's interested in children. But she's also not very compliant because she really didn't like to take Coumadin. Coumadin was a lifestyle issue for her, and it became one that really was limiting to her. The second side of that issue is that we know that her prosthesis was quite small, and the question was, how do we go ahead and enlarge that? So what I'd like to do today is talk about some of these issues very quickly because I think that they're relatively important, and yet I'm going to come up with no obvious conclusion. The basic conclusion is that you must individualize these choices to the patient. The patient ultimately has the decision of whether they want Coumadin or something more permanent in terms of the surgical prosthesis. So these issues come into play in every discussion we have. The second one, which I alluded to, is lifestyle. We frequently have pregnancy, we have activity. If you take Coumadin, there is a slight but real risk, particularly in young people, over time, that they may have a complication of Coumadin, either by taking it too much or taking too little, either then having the tendency to bleed or the tendency to have either thrombosis revolve around the valve or potentially a clot leave. This young woman's outflow tract was even narrower than her 19 millimeter prosthesis because she had some ingrowth of tissue over the years into this small prosthesis, and I think her effective orifice area was actually less than what might be in somebody who had a brand new 19 millimeter valve. The next issue is durability. Obviously, for some people, they don't want to have multiple operations, and if your bioprosthesis has a longevity and you're then going to face certainly another valve replacement, for some people, the durability issue outweighs any lifestyle issue. Finally, the anticoagulation does come into play. When you have a mechanical valve, you must take Coumadin every day. So you must be committed to it. You must be reliable. You must understand the importance of taking Coumadin. And even though this young woman sort of played a little bit of a risk game with it and got away with it, as you get older, that risk goes up, and you must have the Coumadin on board. And finally, the surgical technique comes into play because, as I'm going to allude to, there are some operations that we do are fairly simple, and there are other operations that have the potential to be much more complex. And therefore, we have to then make decisions on what we're doing today based on simplicity versus complexity, but also what it might be like down the road when they face another operation. So then, when we look at this, we come through a number of different issues that the surgeon and the patient has to go through. We want a mechanical prosthesis, a bioprosthesis, a stentless, one of the newer generation bioprosthesis. Maybe take it from another human, what's called an allograft, or maybe start switching your own valves around, what we'll refer to as a Ross procedure. And then we come up to having to deal with the issues like we did in this young woman. Does she have a small left ventricular outflow tract? Does she have a prior pulmonary problem? Or does she have an enlarged aortic root with Marfan syndrome? So these are the kinds of issues that must be dealt with as we face a patient. Now, whenever we have the option of looking at a valve, our first goal is always to repair that valve, because repairing their own intrinsic valve is always more optimal than putting in a prosthesis that either comes from another animal, another human, or out of mechanical carbon fiber or whatever the valve is made of. The replacement issues become 5. And once again, the issues we're dealing with are durability, anticoagulation, and ease of insertion. With those in mind, we then have to look at how those factors come into play with mechanical valves and the 4 bioprosthetic options. Mechanical valves, been around the longest, used most widely in the world. They're important because they're very durable and they're easy to put in. We have a sewing ring, and it's a 2-dimensional valve we put down into that annulus, and it normally works out very well. The disadvantages of it is that because it's a rigid ring, it's not mobile. It doesn't conform to the normal physiology of the aortic root. And for that reason, it gives, even at a larger size, somewhat some artificial resistance to outflow tract, and it changes the flow dynamics across that valve. Plus, you must have Coumadin on board. The stented bioprosthesis, this particular one is made up of the lining from a cow's heart, the pericardium, once again mounted on a stent, easy to insert, no anticoagulation. We sometimes recommend an aspirin, but it's not necessary for the patient to take Coumadin. The disadvantage is that it's not so durable. These stress points that occur where the valve is mounted on it, if you put them into a chamber and look at it over time, they develop calcifications at the stress points. And therefore, they ultimately lead to deterioration. Well, a few years ago, we and a number of other institutions became involved with what are called stentless valves. They don't have that rigid ring on it, and they conform to the root, and they move with the root in multiple dimensions. And the concept is that they would have improved hemodynamics without that fixed ring, and without that fixed ring, they would then maybe be more durable because the stress wouldn't be on the mounting struts, and they would give better hemodynamics. And a number of them were designed. This was the first one, a St. Jude stentless valve, which we were one of the leading facilities to test this valve when it was in trial. And this is the newest version. Once again, the University of Washington is one of 4 or 5 centers in the United States that has availability of this valve in a clinical trial. So it has the advantages of some theoretical design considerations, but its durability is unknown because the longest that this one's even been in is 8 years. So we don't know the answer in terms of the durability. And it's definitely more technically challenging because it's not a 2-dimensional valve. These struts have to be sewn into the wall without distortion, with the height being appropriate. So they're a 3-dimensional valve. So for the surgeon, they're definitely more challenging. So how do we decide whether they're going to be better or not? Well, we don't know. We certainly want to know that the hemodynamics, the survival advantage, and the durability may be issues. And we have a little bit of information. In terms of hemodynamics, in at least one study comparing the stentless and the mechanical at around the same sizes, when you looked at the effective orifice areas, even though at rest they looked about the same, when you then exercised people, you can see that in the mechanical prosthesis, the mean gradient was significantly higher in the mechanical valve, and then when you exercised them, the peak gradient in the mechanical valve was significantly higher. Now, whether that's an improved hemodynamics, it's unclear, except there are a number of these kinds of studies in the literature extolling the potential benefits of a stentless valve. We also know that the stentless valve, that their valve area over time increases, and that's a good thing. That means that they've conformed to the wall, that they've molded themselves into the wall, and that they ultimately get improved hemodynamics over time. The big issue is there a survival advantage? And unfortunately, there is one or two studies that says there are, but there are very few confirmatory studies. But in this series coming out of Canada comparing stented and stentless valves, you can see that the mortality was less with the stented valve, the late deaths were somewhat less, and the actuarial survivals out to 8 years were improved in those patients with stentless valves. This data needs to be confirmed because, once again, the complexity of this surgery has to justify it, and this is obviously a way of justifying it if the data holds up. Finally, is there increased durability? Well, since it's only been in 8 years, we don't really know that, but we certainly know that it's not significantly worse than other bioprosthesis. So at least preliminarily, it looks like a reasonable option. So the answer to this question, is there improved hemodynamics? Probably there are. It makes sense. Is there a survival advantage? Maybe, but we don't really know. It needs to be confirmed. And is there increased durability? That's unclear at the moment. It's just not been followed long enough. Well, what's the fourth option? The fourth option is to take another human valve. So when a patient dies, frequently we harvest organs if they're patients young and the organs are vital, but we still have tissue banks that will harvest pieces of tissue, cartilage for the knee, cornea for the eye, and parts of the heart for use in others. And they're taken out of a person who dies within 8 hours, and they're frozen. And they're actually vital tissues. And we can see that when you bring them down to 37 degrees centigrade and then rewarm them, many of those cells stay alive. And there was great hope that when we had homographs that we would see improvement because they were other humans. There was a question of whether there would be antigenic issues, but it's certainly not the kind of antigenic issues we see when we transplant a full heart. We do know that if you use these in patients who have infection on their heart valves, it's the best solution. Most options for the surgeon and best survival. But once again, it's technically challenging. And the biggest issue with this is the fact that this entire valve calcifies. And when you then have to go back in, you have to carve out all the calcium of the root, and it's a technically very difficult reoperation, having done a number of these now over the years. And that's the reason why this isn't a very viable option. The second, the last option that I'd like to mention is the Ross procedure, because this has gotten a huge amount of press, and it's also gotten a lot of enthusiasm over the years. And this is an operation whereby, because embryologically these two valves are similar, if the aortic valve is diseased, why not take the pulmonary valve and move it into the aortic position, and then reconstruct the right ventricular outflow tract with a homograph, because we have many of those available. And this was an operation described in 1967, was thought to be very technically challenging because it was two valves, but there was a huge amount of enthusiasm in it. And this is an example of what happened. In 1988, when it was reintroduced, over a 10-year period, they went from 38 to over 600 of them done that were put into a registry. But you can also see that since that time, there's been diminution of enthusiasm. And I'd just like to make sure that you know why. This Ross registry followed 4,000 patients. They followed them for almost 70% of them. They followed up for about 3 years. But the problem when we looked at the Ross data is that the acute mortality was 3.5%, and the greater than 30-day mortality was 2.1%. So the overall mortality of 5.6% is really not acceptable when you're operating on young people. And this is what the biggest concern was. The second concern is that if you looked at those that needed reoperation, almost 10% of them in that 5-year follow-up period required reoperation. Once again, too high of an incidence for the operation to be the gold standard. And interestingly, if you look at almost 50% of them had mild aortic valve insufficiency, moderate, moderately severe, or severe. Once again stating that this is a very technically challenging operation, and there are a number of issues that we're going to need to understand in order for it to be the gold standard in young adults. In young children, I think it is the gold standard because the homograph, the autograph grows. So in a young child, it will grow. But in a young adult, these results have raised concerns. Finally, this homograph on the right side, which we had to redo in our patient with truncus. The reason for that is that it's very, very common that the homograph will calcify and stenose over time, probably immunologically. And our experience at UW is that this number of 10% having to reoperate on the homograph on the pulmonary side is probably real. So the pendulum is swung back. It's still part of our armamentarium, but probably not the standard. The final issue that I wanted to talk about has to do with this mismatch. And I think this is the critical concept I'd like to come out with today. That if we had tried to leave that 19mm valve in or put in a tiny valve on the right side, this woman would not have the long-term potential results that I hope she'll receive because we've reduced these gradients. And it has to do with this relationship between body size and aortic valve dimensions. We know that most prosthetic valves, you have a predictable gradient and effective orifice area. We most often see a mismatch in little tiny elderly women. And it's probably not a mismatch in their normal aorta. They wouldn't become elderly if they had a mismatch. But when we put a prosthesis in, we have the potential because we take up some of that area with that sewing ring. And for this reason, it comes up and we're careful with it, but we don't do too many annular enlarging procedures. But in children like her, it becomes different because her effective orifice area is significantly different. And so our patient, if you look at her weight and height and body surface area, and this is the normal algorithm, this is where she sat on her algorithm. And that's one of the reasons why she had such a large gradient across that aortic valve. When we have that, we know that it affects survival after aortic valve replacement. And this is a large series where you compared effective orifice areas less than 0.75, the orifice area to the body surface area, and you can see that in those patients with small annuluses, it does impact upon survival. And over time, it becomes even more pronounced. So that this is the overall survival over 12 years with a mismatch. And obviously, this young woman, if we had left her with that 19mm, I think she would have fit into the lower category. So there are a couple of ways to enlarge the annulus, and you saw what we did in our patient. We opened the non-coronary cusp, we went into the mitral valve, we put a patch on it, and we were very, very pleased to get an increase from 19 to 23. Most of the time, the increase is 1 or 2 sizers. If you need a much bigger increase, then you almost have to make an incision into the right ventricle and into the septum. And when you can do that, you can then enlarge the aortic valve, and then you have to patch a bigger patch down into the septum and then ultimately patch the right ventricle. So what I've tried to do today is tell you that in patients like this, we have to make decisions with the patient. Important to come out with good hemodynamics. The valve choice is one that we must interact with the patient in order to get good results. Thank you.
I'd like to thank our presenters and our audience today for their participation and look forward to seeing all of you at another Regional Heart Center Grand Rounds in the future. Thank you very much.